Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston who has been in practice for more than 40 years. This is a series of lectures on your heart. The focus of this presentation is what questions you should ask if you have been diagnosed to have a valve problem, such as a narrowing or stenosis or leak or regurgitation, as we call it in the medical terms. So, first of all, let us begin with a crash course on heart valves, what their functions are, and how valves malfunction, and what do we do with that, how do these valves present, and most importantly, the pertinent questions you should be asking your cardiologist, cardiac surgeon, and everybody else involved with your heart valve and heart function management, including your primary care doctor. As you know, the heart has four chambers: the right up atrium, the right ventricle, the left atrium, and the left ventricle, and these are all separated by valves. The purpose of the heart valves is to prevent the blood from backing up when the heart is squeezing. When the atria are squeezing, we want the blood to get into the ventricle, and when the ventricles are squeezing, we want the valves to close so the blood moves forward. The purpose of the valves is to move the blood forward and not backwards. If it moves backwards, then it defeats the whole purpose of this pumping function of the heart. It is just like pipelines that have valves to direct the flow in the appropriate direction. On the right side, we have the tricuspid valve, which separates the right atrium and the right ventricle, and the pulmonic valve, which separates the right ventricle from the pulmonary artery. The left side is the more important one, where we have the mitral valve, which is separating the left atrium from the left ventricle, and the aortic valve, which separates the left ventricle from the main artery, the aorta. So we are going to primarily focus on mitral and aortic valves. Occasionally, people can get tricuspid regurgitation, but that is extremely rare. But most often, people end up with mitral stenosis if they have rheumatic heart disease and they get narrowing of the mitral valve. More often in the adult population, we see mitral regurgitation or mitral valve leak because of the dilatation of the heart and the stretching of these leaflets. The blood can leak into the left atrium during ventricular squeezing. And similarly, with aging, there is degenerative changes in the aortic valve that leads most often to aortic stenosis or narrowing. Some people are born with a two leaflet valve, which is known as a bicuspid aortic valve, which is prone for narrowing and also infection. So there are a whole host of things that can cause damage to these heart muscles, like infection, heart failure, myocardial infarction, aging, and all these things have an effect on the heart, and we're going to see how they affect the heart. In patients with aortic stenosis, where there's narrowing of the aortic valve, because there is narrowing of the valve, there is increased pressure generated in the ventricle to squeeze the blood into the main artery. As a result, the heart muscle becomes thicker. As you can see, the heart muscle is thicker compared to the other side. I mean, it's supposed to be, it doesn't look, but that's what happens. It's called the hypertrophy of the ventricular muscle. Whereas in patients with the mitral regurgitation, because of the leak, there is increased volume. Every time the heart is trying to pump, half of it is going to the other side, and it has to pump that the blood that was leaking and plus the normal blood coming to the heart. As a result, the heart enlarges, the cavity becomes large, the walls become thin, and they develop dilated cardiomyopathy or heart failure compared to the normal heart. So these are the two main conditions that we encounter most often in cardiology practice. But the questions that you're going to be asking are going to be very similar because you want to understand everything about your heart valve situation. The first question you would ask would be, what's wrong with my heart valve? What do I have? Do I have mitral stenosis or narrowing of the mitral valve? Or am I having a mitral valve leak or regurgitation? Or do I have aortic stenosis? And sometimes we can get aortic valve leak also. And what kind of symptoms should I watch for? When patients have leak, there's increased work involved in the heart that can lead to shortness of breath, weakness, fatigue, fluid buildup, congestion in the lungs. Those are all the typical symptoms of heart failure in the advanced cases. In mild cases, you may not have any symptoms. You may just have mild shortness of breath with minimal exertion. Whereas with aortic stenosis, you may not have any symptoms until the valve becomes critically narrowed, at which stage you may develop chest pain, sometimes dizziness, and so those are some serious symptoms with aortic stenosis. What tests do we do to determine the severity of the valve leak or stenosis? We do a whole number of tests, starting with echocardiography. It will tell us if the heart is enlarged, if there are irregular heart rhythms associated with valve heart disease, like in patients with mitral stenosis or regurgitation, there could be atrial fibrillation. We also do an echocardiogram to precisely locate the location of the narrowing or the leak, look at the structure of the valves, look at their integrity, and look at the heart size chambers, thickness, their contractility. A whole host of things can be determined by echocardiography, either transthoracic or putting a tube in your throat and looking at your heart more closely. We do stress tests to find out what is your functional capacity with the valve stenosis or leak. Then, if you considering surgery or interventions, we may do CT, MRI, and heart catheterizations to see exactly, where is the problem, how significant is the problem, how is the rest of the heart doing, and what is the most appropriate treatment based on that data. How serious is the condition? Well, the heart valve leak just doesn't happen overnight. It develops over decades. So initially, it may be very mild, where you probably have just, when we listen to your chest, you may have a little heart murmur and say, hey, did you know you had a heart murmur? I said, no, nobody told me I had a heart murmur. I've been seeing my primary doctor for 10 years. Well, anyway, you got a faint murmur, and we're going to do an ultrasound test to see what that murmur is. And then we do the ultrasound, we see there's a mild leak in the mitral valve. When you have a mild leak, we may just follow you on a regular basis and look at the heart size, the heart function, and the amount of leak. But as it progresses, you may start having symptoms with moderate exertion, like you're walking like a mile or so, then at the end you become short of breath. You kind of have to catch your breath, and that may be the first sign that maybe your valve is getting worse. Stage 2 is where you have symptoms with mild exertion, like just walking around the house or going to the mailbox. Things like that may be giving you symptoms. Stage 4 is where your heart is enlarged, the valve is leaking considerably, significant amount, and as a result, you are having symptoms at rest. You can hardly move, you get short of breath, you're fatigued, you're tired, you have heart failure symptoms. So those are the different stages. What is the treatment for a heart valve? Again, it depends upon what stage you're on. If it's a mild one, we follow you medically, and if there are any symptoms of high blood pressure or history of coronary artery disease, those things need to be fixed to prevent the valve leak or stenosis from getting worse. How do we fix the narrowing or leak? Okay, there are several different approaches. Initially, as I said, we generally just follow you medically, and we do the ultrasound test to determine the appropriate timing for the heart valve intervention. It doesn't have to be surgery. The types of treatments could be just doing a catheter and maybe clipping the mitral valves. That's called the mitral valve clipping. By bringing the leaflets together, that's decreasing the narrowing of the leak and reducing the amount of blood leaking. It is not a surgery, it is just like heart catheterization. Similarly, aortic valves can be replaced today in these days through using catheters without you having to go for surgery. The whole procedure may take 2 to 3 hours. After that, you have a very quick recovery in a few days. And if you were to need surgery, the surgeon will come and talk to you and they will recommend what kind of surgery you're going to need. Of course, they have to use a prosthetic valve if it is necessary, or sometimes if it's a mitral valve, they may be able to repair those mitral valves by shortening those, the parachute strings and reducing the leaflet size and thus reducing the amount of leak. That depends upon what is the underlying condition. It's all determined using all these tests. There are different kinds of mechanical heart valves. We have heard about the bioprosthetic or porcine valve, which is made out of a pig pericardial sac. Then we have the mechanical valves, the ball valve and the disc valves. And when patients are on these kinds of different types of valves, they have different requirements as far as medications are concerned. What are the complications? The complications of heart valve leak are predominantly development of congestive heart failure with symptoms of shortness of breath, weakness, palpitation, fatigue, development of cardiac arrhythmias like atrial fibrillation, and sometimes formation of blood clots because of irregular heart rhythms and leg swellings. A patient with stenosis or narrowing may have very minimal symptoms, but by the time they get symptoms, it may be time for surgical intervention or a procedure intervention. People who go on mechanical heart valves need to be on blood thinners long term, lifelong, I would say. Why do they need blood thinners? Because these mechanical valves are prone for developing blood clot. And if you don't put them on blood thinners, the valve may form a blood clot which will block the function of the prosthetic valve and deceive the purpose. Not only that, these blood clots can go to other parts of the body and cause a stroke or blockage of arteries in the legs or in the gut. So they need to be on blood thinners. How long they need to be on blood thinners? As I said, lifelong, as long as they have these prosthetic valves. If they have a bioprosthetic or porcine valve, they need to be on blood thinners for like 3 months, and after that, we can reasonably stop the blood thinners and wash them carefully. What if I need other procedures like surgery when you're on blood thinners? That's a very good point and a very good question. This is something that has to be done as a team effort between the cardiologist, the surgeon, the primary care doctor, and the timing has to be done such that we can reasonably stop the blood thinners for 3 to 5 days during the surgical period, and then treat them with short-acting heparin if they are in the hospital, and then resume the warfarin, which is most often used for valve surgery patients. How long do these valves last? How often do I have to get a replacement? That's a very good question. Interestingly enough, most of these mechanical valves have been shown to be durable even after 15-20 years. So there's a very good chance that the heart valve can last a very long time. The bioprosthetic valves, the porcine valves, sometimes may degenerate and you may need a surgery a little bit earlier than 15-20 years. What medications will I be on? Of course, you're going to be on blood thinners, and if you had any evidence of heart failure, you're going to be on medications for heart failure. If you have high blood pressure, the medications you'll be treated with medications for blood pressure to reduce the strain on the heart muscle itself. Next question is, you heard about, you should be taking antibiotics if you have mitral valve prolapse or if you have a prosthetic valve. And that is true to most cases. If you're having a dental procedure or if you're going through any kind of an invasive procedure, you need to be taking antibiotic prophylaxis. The best thing is talk to your cardiologist, talk to the surgeon or the dentist and see what kind of procedures they are doing and see if there is a recommendation for you to be on the appropriate antibiotic prophylaxis, or it is known as endocarditis prophylaxis. It differs from case to case, so that's why we can't generalize that. Best thing is talk to your specialist, because this is an important thing, because you don't want to get an infection on your prosthetic valve when you're just going for a simple procedure. What lifestyle changes I need to do. Of course, when you have a valve stenosis or a leak, you are going to be having structural changes in your heart. And if you're having structural changes in your heart, or say you're having heart failure symptoms, you need to restrict your salt intake, you need to restrict your fluid intake, you need to be taking your medications on a regular basis, and you need to be following your lifestyles, you need to bring your weight down and control your sugar levels. These are all integral part of a healthy living, because you cannot have heart valve problems and ignore all the rest of the things, thinking that, oh, the surgeons replace the valve, so I can go back to smoking, drinking, and cursing. Well, you can, but you're not going to be feeling good. How do you determine the right timing for intervention? This is a very important and good question. When do we determine, okay, you need mitral valve replacement or mitral valve repair or mitral valve clip? This is determined by multi-specialty teamwork and discussion, because any intervention is invasive and it is going to have some implications. So it is done by doing an ultrasound test or TEE, CAT scan, MRI, and after all these things, we determine where exactly we can intervene with what kind of procedure, and then the intervention is done. Also, it also depends on the heart function. If the heart function is normal and if the leak is mild, we just need to follow you medically. But if you have a severe enlargement of the heart and your valve leak is giving you severe symptoms where you're short of breath just walking from bedroom to bathroom, then some intervention or any type of intervention may help you to improve your quality of life. How long will the heart surgery take? If you need heart surgery, it's a pretty long heart surgery. I worked at the Texas Medical Center. I have watched many heart surgeries done by Dr. Denton Cooley, Dr. Livesey. These are some of my favorite surgeons. Sometimes it can take some 5-6 hours, but the whole procedure will more or less run the whole day, because right from the morning you're taken to first of all to the holding area, then you have to go through the anesthetic workup, anesthetic evaluation, and anesthesia, surgery, and post-surgical recovery. All these different things happen. And you may want to talk to the surgeon or get the information from other sources as how many heart surgeries has the surgeon done? How many heart valve replacement has the surgeon done, the kind that you are recommended? And what is their success rate? These are sensitive data, but you can actually get it from like a nurse manager or like a clinic coordinator, and they will be happy to share the data with you. In this day and age, everything is black and white, and a lot of times you see their data on their websites. Can we fix the valves without surgery? Yes, as I already mentioned, with a mitral valve leak, if it's mild to moderate, it can be fixed with mitral valve clips to bring these leaflets together and decrease the amount of blood backing up into the upper chamber. In case of aortic stenosis, nowadays we have a choice of going through the catheters and replacing the aortic valve versus open heart surgery. More recent data shows that people who had this catheter-based aortic valve replacement, known as TAVR, T-A-V like Victor, or TAVR, has results similar to those seen in patients with. The timing for aortic valve surgery is whenever somebody has chest pain or dizziness or blackout or irregular heart rhythm. When they develop this, their condition deteriorates very rapidly, and hence they need intervention as soon as possible. Okay, ladies and gentlemen, this is a very quick rundown of some of the important and pertinent questions you should be asking your doctors if you have been diagnosed to have any kind of valve problem. There's one more valve problem which we rarely see, which I mentioned in the beginning, the tricuspid valve regurgitation. And there, very rarely they need to replace the tricuspid valve when they're doing open heart surgery. On the left side, they can go and reduce the valve size by removing some of the leaflets, extra tissue, and thus reducing the regurgitation. But that is very uncommon, and the results are plus minus. But anyway, main thing is we have very good success rate with mitral valve surgery or interventions. We have very good success rate with aortic valve replacement or TAVR, and it is your part to ask all these pertinent questions. And I have similar presentations on coronary artery disease, atrial fibrillation, pacemaker, heart failure, and please do watch them. Become an educated. Thank you so much for watching, and please do share this video with your friends, and please do subscribe to our YouTube channel, and I will see you in the next video. Thank you.